Hello, and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA Wrap. I'm your host, Raj Gupta, coming to you from Nashville, Tennessee. And we have an amazing panel of people today to talk about an upcoming symposium on green anesthesia. I'll do my introduction shortly, but I just want to make sure people are aware of a couple of things coming up. Obviously, the symposium is going to be coming up on October 1st, and I encourage you to go to ASRA.com and register for that. I think it's going to be fantastic. It's the first time we're doing this topic of green anesthesia, and some people may wonder where regional anesthesia, general anesthesia, and all of that coalesce into a topic that's appropriate for this society, and so we'll get into that shortly. The other thing is of course, the ASRA fall meeting is coming up. It's going to be in person in Orlando. Go to ASRA.com because the registration is open right now. Well, we just sent out the approvals for the abstracts. It's a tremendous number of abstracts were submitted and accepted to the meeting. I think we're on par for a record number. I think the meeting's attendance is going to be gangbusters and will be a phenomenal experience to be there in person. So I encourage you to go to ASRA.com, register for the meeting. Be there with us in Orlando. I'll be there. Come say hi to me if you are at the meeting, and I'm looking forward to talking to you there. So without further ado, let me get the rest of our guests on the screen here. So I'm going to read your introductions because I'm going to make sure I don't miss anything. You guys have esteemed careers already, so I want to make sure I catch all of this. So first, we have Vivian Ip. She's a clinical professor in the Department of Anesthesia and Pain Medicine at the University of Alberta in Edmonton. Vivian, I was actually just in Edmonton recently. I could have reached out to you. We were there for a short time.
Right.
So she's a practicing anesthesiologist with fellowship training in regional anesthesia and pain medicine and ambulatory anesthesia. She's the director of regional anesthesia and acute pain and the director of ambulatory regional anesthesia at the University of Alberta Hospital. She's the chair of the ASRA Pain Medicine Green Anesthesia Special Interest Group. We'll talk about that more. And chair of the Canadian Anesthesiologist Society Environmental Sustainability Section. She's the vice chair and editor of the ASRA Pain Medicine Newsletter Committee, and she has no conflicts of interest to report. Vivian, welcome. Thank you for being here.
Thank you. Thanks, Raj.
Next is Deirdre Kelleher. She's a regional anesthesia and acute pain anesthesiologist and the chair of the Anesthesiology Sustainability Committee at Weill Cornell Medicine in New York. She's passionate about finding sustainable alternatives to current anesthetic and healthcare practices and reducing the environmental footprint of care while improving its safety, efficiency, and cost effectiveness. Shares the best practices as the newsletter liaison for ASRA Pain Medicine, Green Anesthesia Special Interest Group, and she also has no conflicts of interest to report. Deirdre, welcome.
Thank you so much.
It's great to have you here. I'm really excited to hear about some of the ideas. I think about this all the time as I'm working in the operating room, but sometimes lost to know what to do. And then last but not least, E.B. Fouts-Palmer. E.B. is an assistant professor of clinical anesthesiology at Weill Cornell Medical College in New York. Her interests include environmental sustainability and physician wellness, and she's particularly passionate about the role of anesthesiologists as advocates for patient safety and public health. EB has no conflicts of interest to report. My only conflict is I do this podcast, which I don't make anything for, and I'm on the board of directors for ASRA Pain Medicine. So thank you guys. Welcome. And this topic, let me kind of introduce it. So Vivian and I had been talking a while ago about their special interest group, the Green Anesthesia Special Interest Group, a really fantastic group within ASRA Pain Medicine. And they were excited about being able to present their topics to a broader group of people in a formal presentation. And so they had the idea of this symposium. And over the last year, they've done a really remarkable job. You guys have done a really remarkable job of putting this together and actually having it get set up to go for October 1st. So this is an online webinar kind of experience. It's a full program with wonderful speakers, really talking about a broad set of topics about how we can be more green. Vivian, you want to kind of introduce a little bit more about the topic, where you guys were coming from, and where, and I know this is a sort of a joint effort between ASRA Pain Medicine, but there's a significant component from the Canadian Society as well, thinking about, and why ASRA Pain Medicine is the society that really should be talking about this too.
Yeah, well, thanks very much, Raj. Thanks for the opportunity. And I still remember our conversation and you reaching out to me and say, "Hey, I think your idea is doable." I'm like, "Wow, yeah, let's do it."
Yeah.
And I still remember you saying, "Well, let's plan some topics and get a full day." And then, we're all busy with the planning committee with Deirdre and Ip and Rakesh, Timur and Rachel. And then it just all happened. It's happening, very soon. So I'm very excited about it. So firstly, I think regional anesthesia and environmental sustainability go hand in hand because I feel that, have something that, be able to anesthetize the patient's limbs for surgery without the need for volatile agents, which is a very potent greenhouse gas, is always, a plus. And obviously, when we are actually doing our anesthesia, then we also always need to be cognizant that we are actually potentially using more greenhouse gas or producing more greenhouse gas than our average population, because they don't, for our full day of general anesthetic, we could potentially be driving from San Francisco to New York 3 times, in an 8-hour day. So we just always need to be cognizant of, every single time when we turn on the volatile agent. So I feel that if we can, avoid the general anesthetic and the volatile agent, then is a plus, for sure. That's why I feel that regional anesthesia and environmental sustainability goes hand in hand. And later on, we'll have Deirdre and Ib talking about how they also, the institution actually promote getting rid of desflurane, which is an even more potent greenhouse gas. So I feel that this symposium is going to be great because we have speakers from all over the world. In fact, our keynote speaker is from the UK, is Dr. Hugh Montgomery, who's just been awarded the Most Excellent Order of the British Empire Award this year for his work on climate change and health. And so he'll be talking about the environmental impact and healthcare. And so we also have speakers from all the way to from Australia. So Fouts-Palmer, who will be speaking to us about environmental challenges and things like that. So it's we that's the beauty of having virtual symposium, is that we can invite speakers from all around the world without too much carbon footprint. We in the program as well, we also have things like perioperative environmental sustainability strategies, which is very, very close to our heart. We have acute pain, chronic pain, and why we need to avoid general anesthetics. And TIVA is also very good as well, but also it has its own problem. So we'll go through the strategies and practical tools for people to use in their practice to be more environmentally sustainable. It is an urgent problem, and I like everybody to know that as well, because unless you recognize that this is a problem, it's very difficult to encourage people to do something about it, to be motivated. And that's why we have a wide variety of topics, like circular economy. If you don't know about that, you want to hear about that, that's certainly lectures on that. And just to broaden everybody's knowledge, to give people tools to actually make a change. And don't think that, it's too late to make any changes. Anyway, any change is important, especially we are closer to the target limit of raising the temperature of 1.5 degrees Celsius, as the IPCC, the Intergovernmental Panel on Climate Change, has already put out a warning to urge all of us to take action. Yeah. So
that's a great introduction, Vivian. I mean, I think all of us, probably most of us in medicine, see the effects of climate change are happening all around us. It's hard to realize that us turning that little dial of gas in the anesthetic is part of the problem and potentially part of the solution, or at least the reduction of that as part of the solution. Deirdre, you mentioned that in New York you have already you have that itch when you walk around and you start seeing stuff that you can change. I think a lot of people share that feeling, but often don't know how to take action on it. Talk to us a little bit about where you saw action and places that you guys have worked on.
Sure. Yeah, I think as physicians, it's especially important for us to set an example. And even though some people will say, well, our impact is only a certain percentage of the world's impact and that we should be focusing on industry, I think as physicians, we should be setting the example and making sure that we're doing the right thing. And so honestly, the way I've approached it is just when there's two choices in front of you, just try to always pick the better choice. And that's kind of how I've always helped people through their kind of conundrums of, well, should I be doing TIVA and getting rid of volatile altogether? I'm like, well, if you have to use volatile, please just don't use desflurane and nitrous, just choose the other one. And if you can do it with low flow anesthesia, that would be great. So what we really started with here at Cornell was working on getting rid of desflurane. We had a really bad culture of thinking that desflurane was okay to use. We had fallen into some marketing traps of thinking that desflurane was, equivalent to sevoflurane if you used it with low flow, both in cost and in cost to the environment. And so we worked on gathering a lot of educational materials to show exactly what the numbers were here at Cornell and how much we were spending on desflurane and how much carbon emissions that resulted in kind of on a monthly basis. And then we did a giant literature search and showed that there were some initial studies that said that maybe desflurane is better in some certain circumstances, maybe in the obese population, maybe in the elderly, maybe for neuro. And so, we brought that to all of our faculty, and the faculty agreed that maybe we could just take out the desflurane vaporizers from most of the rooms, except a couple of the ones that, maybe in the rooms where we do bariatric surgery and neurosurgery, and everywhere else you would just have to ask for it if you really wanted it. And everyone was on board because, for the most part, you were either in the camp of wanting to save money or in the camp of wanting to save the environment. Some people were both, obviously. And so, there was strong support to do this, which we just really hadn't been able to get before because, people just kept quoting these papers that, well, you're actually saving money in the operating room. And so overall you're saving money. But when you really showed them the facts, they really understood. And we dramatically within a month, we saw a dramatic reduction. And then over 12 months, we reduced our carbon emissions by almost 90% just from our desflurane contribution. Obviously, that included whatever increase we used on sevoflurane. And so, it did include propofol or things like that. But for the time being, we were only focusing on getting rid of desflurane. We weren't even telling people to use TIVA. So honestly, I think that the swap was really to sevo. And so that was a really dramatic and positive thing. And now our residents, they were like, what do you mean when you were a resident use desflurane for every case? But I did. I'm so embarrassed, but I did because that's what my attendings told me to do. They said it was fine. And so it's pretty impressive to see a culture change that quickly from something like that.
Yeah, just gonna add, I think it's also a really great example of making a system change to make that individual change easier. Like, I feel like we often wind up getting into the sort of individual versus system thing, but it's so easy to just turn it on when it's right there and use it. And when you have to we still have them. We can call and ask somebody to get it. It's not that hard, but hardly anybody does it.
See, that's a very good example of like a knowledge gap, and people just don't even know that, some, like, especially in the early days, people don't even know that actually desflurane at low flow is not equivalent to sevoflurane at, just 1 liter flow per minute. And you shouldn't be using 1 liter flow per minute anyway. So I think this is very important. And that's why, again, like coming back to the symposium, is like you will learn lots more and new things that you don't even know that you don't know.
Right. And it's hard to do something about something that you don't know that you don't know.
Right.
Deirdre, your example is so interesting because individual change to make system change, oftentimes we have more influence over that than we realize. And it sounds a little bit cynical, but I found that often most people will do things that have the path of least resistance. And if you can put any kind of barrier to the direction that even a little tiny speed bump in the direction that you don't want them to go, that most people will just not go over that speed bump and they will go the other way as long as that's easier. And so we've found that I created a system years ago, and it has nothing to do with green anesthesia, where people were ordering like 10 different variations of epidural infusions because everybody had their custom order and different local anesthetics, different narcotics, different concentrations. And I said, no, we're not doing that. We got one order set, but I gave an option in there that they could put a custom selection. Everything else was a pre-click, but they had one custom selection. And I set it up so that if anybody ever put anything in there, it sent me an email. So I knew that they did it. I never got one email. Nobody ever used that little custom option. They didn't want to type it out. They had to physically type out the name of the drug they wanted, and nobody did that. And little things like that can affect change. We're actually in the process in our institution, they put QR codes on the vaporizers, and they're informational. So if somebody's in the operating room on the vaporizer for sevoflurane, you hover over it and it comes up with a page talking about the environmental impact of anesthetic gases, low flow anesthesia, the difference between the different gases and nitrous, and how that affects the environment, so that that helps with that knowledge gap component. And
yeah, we did something similar. We have placards now that at least say the different environmental impacts of the different volatiles, and has a little, we're trying to teach low flow anesthesia, which is our next barrier, that everyone still wants to use 2 liters per minute with Sevo. And so our clinical
because it was taught, that was how we were taught. It's bad for the patient to have low flow with Sevo.
Yeah. Even with education, that one, we've still had a little bit of a barrier. So we started with the placards to at least, we put the FDA recommendations, which actually say that you can go below 2 for 2 MAC hours. And so at least for people to feel, if they don't want to veer from FDA, we put what the FDA says up there, so they can't even, because they can't, otherwise they're misquoting the FDA. Right. And but we're working on a couple of the things, and we had talked about QR codes and maybe doing like a weekly message or something. So I'd be interested, to hear more about your success with that as well, of course.
Well, we just instituted that, so it'll be interesting to see. And the cool thing about having electronic medical records is we can actually pull people's flow rates out of the system and then see, like, does that match up with a change in intervention, and do we have a drop in flow rates? What, EB, when you guys are working, we were talked about desflurane. Talk to me a little bit about nitrous, because this was where my knowledge gap was, we knew that nitrous was bad. I didn't realize how bad it was. Yeah. Talk to me a little bit about nitrous.
Yeah, it really is one of the worst. And it's not just because it's the global warming potential. Like, initially, if you look at the 10 or 20 year, it looks similar to that of sevoflurane, and you think it's not that bad. But then when you start multiplying it out by the amount that you're using, because you're using obviously a lot more nitrous oxide in order to get a half MAC, and then the fact that it also lasts for 114 years in the atmosphere, that it starts to become much, much worse. And a lot of we go through this in our article in ASRA News, but a lot of the articles on this sort of emphasize this point that all seems to kind of go back to one single calculation of how the healthcare industry is such a small portion of the whole, because nitrous oxide emissions also come from agriculture and a lot of other sources. But again, it's one of these things where, like, if you don't have to use it, we don't want to use it. And if you have a choice, you can avoid nitrous. And it's really, I think it does get a little more complicated, particularly at the hospital that I work at. I work at Lower Manhattan Hospital. I work at one of the community hospitals. So even though I'm in the same department as Deirdre, I'm actually not at the same hospital most of the time. But at least here we have nitrous oxide for OB, which is a kind of a big selling point for labor pain. And it's really hard. Like, it's, again, the sort of, when it's there and it's right in front of you and somebody wants it, it's hard to, like, look at somebody and be like, well, are you sure you want this thing that might help your pain? Because it also causes global warming. But it's something that I think we need to think about in advance so we can make better decisions about how we're planning these things.
Yeah. I mean, go ahead. Sorry, Deirdre.
Well, I was just going to say, I mean, the OB, the Entonox is something that, you know, it's rising in the United States, and it's actually kind of crazy because it's not as effective as an epidural, as we all know as regional anesthesiologists, and its impact on the environment is so much worse. It's almost 300 times the amount of the impact. That includes all the plastics and everything that have to be manufactured to place the epidural and the infusion itself. And so it's just crazy to me that we're going in the wrong direction. And additionally, there's so much questioning about the effects of an epidural on the health of the baby. And, you know, that article that came out earlier about it, you know, effect on, you know, brain development and stuff like that. But there's evidence that nitrous causes this problem too, and it readily crosses the placenta. And so it's, you know, there's all these negatives to using it. But then when people write about nitrous oxide, they write about it with these titles like the aging gentleman. And because we've used it for hundreds of years, it's fine. And I'm like, okay, like, no, like we have better drugs. Like, let's not hold on to it just because we like to say we use the same thing we've used forever. Like, I just think it's time to, you know, move on from the
Yes, well, I absolutely agree, and that's why patient education is so important as well. And then the symposium again. I'm just going to go back to the program again. We do have a patient representative who works in the UK to actually come and speak to us about how to approach patients and how to, you know, work and collaborate with patients and get their perspective and educate them so that they can make a decision, and maybe they can work with healthcare providers to actually change the culture, change the mentality. I remember one time we were doing, for World Anesthesia Day, we were doing this booth. We were just sitting at the hospital entrance and telling people about the environmental sustainability in anesthesia. And I remember this 10-year-old girl just came up to us and say, hey, you know, I want to know about this. Let me, you know, tell me more. So we were telling her about the anesthesia impact, and it turned out that she is like a frequent, frequent visitor because she has to have procedures every so often. And she said, right, okay, next time I'm going to talk to my anesthesiologist and I want an environmental sustainable anesthesia. I'm going to tell him that. I'm going to tell her. So it's awesome.
Yeah.
And what you're talking about, such an international faculty. I'm pulling up the program here. Give me 1 second and I'll have it to show on the screen. Where do you think, you know, the motivations, the politics, the finances of medicine are so different across the planet in different countries? Who do you think has aligned their incentives properly to motivate departments to do better as far as green delivery of anesthesia, be more conscientious of this? Where are the places that are working, and then what are the driving motivators there?
Yeah, I think in the UK they actually leaders into this because they are looking at the net zero healthcare, or energy consumption from healthcare. And Cliff Shelton is part of this, who is also a faculty as well at the symposium, and he's one of the, I think, partner or driving force for this initiative. So I feel that the operating room managers and those who are actually on higher level also need to be aware of the problem. And that's why the symposium is also catered for the managers. And we have faculty, not just, from the medical field, but also engineers, managers, patient advocates. Because I feel that it is time for, healthcare to have accountability for what they do. And a top-down approach to say, this is what we're going to do, might be a better driver for changes. The changes that we actually need very quickly, because we are already seeing the impact of climate change. I mean, this summer, it is very hot. I can't believe it's so hot in Edmonton, and we're still having warm temperature. I'm like, well, usually we have snow by now, but no. And in the UK, where my mom is, she said, no, the grass is all yellow because they have no rain, which I'm like, it's unheard of. Like, no rain in the UK, it drizzles all year round normally. But yeah, she sent me a picture.
Yeah.
It's yellow. The grass is yellow, and they are having like 43 degrees centigrade temperature, which is like shocking. So yeah.
I'm having trouble with my screen sharing, so the text was too small. I put the link down here at the bottom of the screen for those of you guys want to go to the program website that has the entire program. I'll read off a couple of the topics here just so you guys are aware of what's going on. So the first is why code red for humanity. Second is greening the perioperative area, to waste or not to waste, and then challenges implementing change and brightening our future. Those are the big chunks of time. This is a full day symposium. You guys have a tremendous number of topics. I don't want to go into every little section of it. Tell me a little bit about something that I'll start with you, EB. When you were helping kind of with the program and the projects that you've been working on, where do you think stands out as low-hanging fruit for people? I mean, we talked about the anesthetic gases, but if you're somebody that works in the perioperative arena, what do you recommend if one of these topics were like, don't miss this part of the session? Like, where do you want people to go? Because that's actionable. You can have your pet topic if you want.
Yeah, I mean, I'm totally gonna like plug my own talk because I also don't know the details of anybody else's talk. But my talk is actually the one on I forget what it was even called. I think it was environmental sustainability, the role of the regional anesthesiologist for environmental sustainability, which I feel like is we've already been talking a lot about how terrible inhalational anesthetics are, and of course we're all regional anesthesiologists. We always want to block something, so it's very easy to sort of slide into the like, yeah, we should just block everything. And I try to make my talk a little broader than that. I don't want to completely spoil it, but I've already mentioned like the sort of individual versus systemic change is a big thing of mine, and also try to get in a little more about like sort of what it means to be a regional anesthesiologist and to think about like what we're good at, because we're good at putting needles in places and getting local to the spot we want it to, but we're also I think we're really good at innovation and coming up with creative new ways to approach things. That's something that's always been a really big part of our specialty. And I think we might not have the solution to all of our problems at the symposium because there might be somebody in the audience who hasn't come up with it yet. And I think that would be the dream outcome of all of this. But I really did try to, I really want to make a plug. I don't know how good my talk was, but I did it. It was recorded. But even if you're not a regional anesthesiologist, because obviously we're now ASRA Pain Medicine, so the pain medicine people, you should definitely come too, because I have a whole activity that you can go through about thinking about what you're good at and how you can affect change in your own practice. I think it would be, some of it's applicable to anyone who's not even an anesthesiologist. So you even bring your family for that part.
Absolutely. And there's actually a session on chronic pain and environmental sustainability, which Dr. Ariana Nelson is going to talk to us about that.
Yeah, I think that sounds like an excellent talk, EB, and I look forward to hearing it. I think it is very important for regional anesthesiologists to realize, what we're good at, and to think about, though, our individual practice of how we could even do better. And I think, we think, well, we're picking the better option, right? But we have that article out of Australia from Forbes McGain that shows that sometimes when you practice regional anesthesia, it might not be the best if you haven't, lowered your oxygen levels, or you're using a bear hugger that has a lot of electricity or anything like that. So there are ways, even in your regional practice, to look at what you're doing and then evaluate it. So I think teaching the tools, obviously a lot of these sessions will be educational to give you the information you need, but also just teaching the tools for people to look at their own practice and then also look at their global practice and see if there's something that they can advocate for. They can go to those nurse managers or the executives and say, I think we should put some dimmers in our OR lights or something that, you can reduce your electricity or something that you've learned from this. I think that's the goal of all of these sessions. So.
Yeah. And I think also things like advocating in your community for better sources of renewable energy. And that's, I think, as physicians, we also have a role as, I think you mentioned this in my bio, as a role as patient advocates and seeing that there's a problem and understanding that it's not just a simple fix for us, but there need to be bigger systemic changes and speaking up about that.
Yeah, and to go back to a question you had earlier, Raj, about which country is doing a good job, we can all kind of agree on which one is probably not doing a good job. And I think
that's
it's
the place with the most opportunity is for improvement.
Honestly, yes. And we have our healthcare system is about, I think the number is about 25% of the global healthcare, global emissions. And so, we have a lot that we contribute. And so I think we have a lot where we can save. And so I think, our focus has been on safety for the patient in front of us. And that is, reducing the risk of any infection. If that means, you watch the orthopedic surgeons put down 20 drapes and like a drape just falls on the floor. And if a company tells them that this new product that is, 3 times as expensive and wrapped in 10 things of plastic is going to prevent one infection, possibly prevent an infection, they listen to that, and the hospital listens to that, and they buy that product because they don't want an infection, because that's what we're being marked on. And I'm not saying we shouldn't do infection control. We certainly should, but it should be evidence-based. And, I think we've been fooled for so long because we just listen to, well, that's an infection. It's going to reduce infection. So we're going to do it. We're going to wear a sterile gown for an epidural. When, we've been doing epidurals forever, and there's not that many infections if you do it properly. And I don't think adding a sterile gown is going to add anything to it. So those kinds of things I think are important to recognize and shift away from just the patient in front of you to thinking about a little more globally of that. What about that patient's children and child and grandchild that, they're going to be patients later? And are we creating more problems down the road for them by having an environment that they can't live in?
Vivian, I'll pose this question to you, and you may not have an answer to this, but I often sit and wonder, and Deirdre kind of alluded to this, is about where unintended consequences of policy change lead to decision-making and potentially marketing campaigns that take advantage of those policy changes. The one that sticks out to me and has been just an irritation for me since the time it happened is when we went to single-use laryngoscopes. Drives me up the wall that was a change. And, I know there's been, I can't remember if you were there at the lecture, but there was a lecture I listened to recently about what the environmental footprint of those laryngoscopes are. It's massive. And, there was a lot of polishing the turd on that conversation when they talked about, oh, don't worry, everything's recyclable. And that's obviously a little bit of marketing speak going on there, but it's interesting if you track back, like, why did that change happen? Like, who instituted the policy that made that change go to effect? And it's been a massive change across the country. The amount of change to single-use laryngoscopes has been tremendous.
Yes, so, absolutely.
Thoughts on that? I mean, not on that particular topic. That's my own little pet peeve, but about how we as physicians get involved in that policy level where it affects those downstream decisions.
Exactly. And it's going back to what Deirdre has alluded to. We need robust evidence. And then our practice should be evidence-based. And not just because this drug reps say, it prevents one case of prion out of whatever, millions of cases. And the incidence of prion disease is so tiny that, are we even doing anything really useful? I mean, look at the big picture. But of course, especially, I have to say, I'm very fortunate that I'm in Canada and that we don't have that sort of marketing level yet. But I know in the US, just because the practice is different and there's a lot of litigation or fear for litigation, and that's why the hospital itself, they will just buy anything that's, even remotely by reducing 0.0001% chance of whatever. And so this really needs, leaders who are also environmentally conscious and also, have kind of, I guess, a sense of looking at the big picture. look at the context. For example, one example is, okay, everybody's worried about drug shortage. But has anyone looked at food shortage? What about shortage of water? Right? Just look at the big picture. So that will be even more detrimental than this tiny little thing that you're trying to prevent, which is really neither here or there. And so I feel that there should be more of us, environmental conscious people who are leaders and actually speak to these policy makers and be actually part of the conversation and say, hey, listen, look, what's the evidence? What's the true evidence? What are we actually doing here? Are we, in the context of everything, are we actually helping humanity or not? Don't just look at this little tiny microscopic thing. I think that would be, that'll be one of the strategy. I don't know whether Deirdre and Ip has any thoughts.
Yeah, I mean, I think honestly, getting this, one of the other reasons for this symposium is to really bring people together and realize that as a group, we could make a difference and actually say something. I think for too long, we've given up control to our, especially in the US anyway, to our regulatory bodies who come to the hospital and give us recommendations for best practices that aren't always evidence-based. For example, the OR jackets that came in for a year or two that we were all forced to wear that were, it was millions of dollars that were wasted. Plus, I can't even imagine the CO2 impact of just those couple of years where we all had to wear OR jackets.
And they were made of plastic. Everyone thought they were cotton, and they were made of plastic.
Everyone calls them paper. They're actually autoclavable 3 times. You could rewear them. But, and a couple years before, they had just gotten rid of white coats out of the OR. And I was like, how are these any different? But no one wanted to listen to me. And so I think that we need to be able to go back to these bodies. And when they make a blanket statement of, well, what are you doing to prevent infection? I see people aren't wearing jackets and covering up their arms. And instead you say, instead of just, oh, well, we'll buy them, we'll make everyone wear them, say, we have our physicians wash their hands between patient interactions and anytime they notice that they've been contaminated. And washing your body and washing your hands is better than wearing a jacket that's been contaminated and then you don't switch it. I think that we've just been so fearful and we haven't taken control. But if people come together and actually advocate for common sense solutions as opposed to the fear-based solutions. And if we all know that we're all in agreement, then we can move forward with that. And I honestly think that's where it comes down to with the laryngoscopes, is that it's very fear-based and also marketed. That the marketing is that they're cheaper, and we do have a life cycle analysis that shows that if you use the reusable ones, I think it's 3 times, 2.5 times, something very low, it's cheaper. And that includes all the reprocessing. It's cheaper than these disposable ones, but the companies are obviously going to want to sell their product that they're going to be able to keep selling and selling and selling. So, it's a problem because we're a capitalist society and, they want to sell products. So that's the other issue.
Yeah. And that's why the people, oh yeah, Ip.
I was going to say, and I think a lot of the regulations are also, frankly, just confusing, and it's hard to figure out how to change them. Even just to figure out what the regulations are. I don't know if you've ever tried to actually just look up what the regulations are in any of the Joint Commission. So it's just buried under something you have to buy, and you can't find it. That's hard to even argue with it.
That's the thing as well, that I think we, as environmental conscious healthcare providers, we need to take the lead and be on the procurement committee as well, because if we want to be heard, we need to be there and speak up. And also collaboration is very important, because as a group we can maybe push out position statements, practice advisories and things like that, and just gather evidence so that we can challenge them and actually challenge the thinking, and to encourage triple bottom line and doing the right thing.
We've had obviously a very interesting conversation, but I don't want to take away anything from the symposium. You guys have so much more information to share. I can see you on the edge of your seats ready to say more. And I'm going to wrap up this conversation today because this is a teaser for the symposium. And clearly there's so much more to talk about and to learn. I have tremendous amounts to learn myself, even though I'm paying attention to this and I consider myself aware of it. Sometimes I don't know what to do with that awareness and how to put that into action. So I hope I'm going to put the link up on the screen one more time. I'm going to tell you guys to go to this website, ASRA.com. It's one of our events. You can go there, look at the whole program. Again, extensive program, really wonderful. This is qualifies for CME if that's important to you. You can get CME from this, but it's just an amazing learning opportunity, if nothing else. And go register for the program. It's October 1st. It will be recorded so you can watch it afterwards. So if you can't watch it live, you'll still be able to watch the recorded version of it afterwards. But, with the live component, there is a certain amount of interactivity you can have as well. So I encourage you to join in real time. If not, it will be a reference for later. The other thing I'll do is I'm going to plug the special interest group. ASRA has these special interest groups, and when the green anesthesia special interest group came to the board, we were kind of confused about where it would fit within the society, but they have really thrived and shown that this group of people are strong advocates for improving the care we provide to our patients while providing a more green perspective on the anesthetic care. It doesn't mean that quality of care goes down. We can improve the quality of care at the same time. So I encourage you guys to go to those. I want to thank all of you for joining me today. It's a wonderful conversation, and I think directly actionable after you get done going to the symposium. I think everybody who listens will have at least one thing to fix at their institution, and that's the start of the second, third, fourth, and fifth things that need to be changed. So I encourage you guys to do that. Thank you guys. Have a wonderful day. I really appreciate it. And go to the website and register. Thank you, everybody.
Thank you. Thanks, Raj,
Thank you,
for
Raj.
inviting us. Thank you. Bye.